here as long as I can stand. I'm an elderly gentleman, so I may be seated soon. I'm going to come to you today from a pretty different angle. And first of all, I was so impressed by the previous speaker. My gosh, what a story. And what evidence of what medicine the right way can do to impact individual lives. And isn't that really what it's all about? How medicine collectively addresses the problems of individuals, the needs of individuals. And that's a very dramatic story, but there are those stories times the tens of millions around the country. And our healthcare system is really failing most of those people. They don't have good access. They don't have good information. There's not good flow and continuity of the patient care. The information is siloed away somewhere. I have to call a hospital and pay them some money to give me some copies of a record that I was there. And it's the reverse of everything we know about every other business and industry. Every business and industry I know of other than healthcare and education and incarceration, which is where the states spend most of their money, right? Medicate, educate, and incarcerate. And those three are so hidey bound by the way they've been done for the last 100 years that they're all failing miserably for different reasons, but all failing miserably. And I was part of that miserable failure of healthcare for 50 years running hospitals successfully, taking underperforming hospitals, improving the quality, expanding the services, becoming the best place to work in the community in San Antonio, going and taking over 8 hospitals, Detroit Medical Center up in Detroit before the city went into bankruptcy. What idiot would do that? With Blackstone as my partner, we invested $200 million to buy the place so they could pay off their debt. We invested $850 million to rebuild DMC. 6 of their hospitals were inner city. 8 hospitals in Detroit, 6 of those are DMC. Everybody else is left for the suburbs. They've gone where the insurance is and where the affluence is and where the patients are. So here's this dying system in town that has no capital, is not well managed because it's not professionally managed. It was well managed by Mike Duggan, who's now the mayor of Detroit, who was our CEO for 3 years. But 5 years later, DMC went from a losing system that had no capital and was rent to own for everything. It's not just the rent to own for the TV and the other things you can't afford, the rims and the wheels. This was rent to own for every piece of equipment in the hospital. So their costs were just outrageous. So we came in with capital. We invested $800 million. And now 5 years later, this system has become the #1 performing system in Tenet, to whom we sold our company 3 years ago. It's become back into the leadership position it had in Detroit. They have some problems going on at the moment, but that notwithstanding, it's a system that turned around, and we've made $1 billion investment in that system and radically transformed what was going on in Detroit. And that was not enough, because what was happening is that half the employees at my hospitals didn't have a primary care physician. Most of the people who came to our hospitals came to the emergency room. That's not where they should have been. They didn't have any place else to go. These are inner city residents, they came there. And so the reason I got out of the hospital business after 50 years is I was failing miserably at trying to be a part of how do we provide healthcare services efficiently, effectively, conveniently, high quality, good experience on the part of not the patient, but the people we serve. And too often we think of them as patients. Think about the organized healthcare system. Everything's done at our convenience, right? And you've seen Topol's book, The Patient Will See You Now, and I think that's a forerunner of where we're going. The patient will see you now, and that's a lot of what you've talked about and you're going to hear about in this conference. But let me give you the sad news, and I'm very politically incorrect. I'm not in the hospital business anymore, so forgive me for all these things I say. But the biggest problem to innovation in healthcare are the existing players in the healthcare system. It's the large hospital companies and smaller hospital companies, for-profit and not-for-profit. It's insurance companies, for-profit and not-for-profit. It's pharma. It's device makers. These are the people who are the problem. Because collectively, if we came together and said, How do we make this system work better for the people and forget my narrow interests, forget my silo? I'm a hospital guy. I want to fill up hospital beds. I don't want to keep patients well. Why would somebody buy a wellness program from a hospital, for God's sake? We need people to be in hospital beds. And the more acutely ill they are, the better. And the more insurance they have, the better. And I can take every one of these segments and show you why they're so dug into their current positions. And this is where the ACA came from. Out of this compromise that says, let's get the industry to solve this problem. And look at the wonderful the solution that we've come up with the industry's help. What's happening to drug costs? Specialty drugs, the noted places where prices go up 600%. What's happening to all the insurance companies who had this guarantee, these corridors that were going to not let you lose money for 3 years? And unfortunately, Senator Rubio, threw a little monkey wrench in those works and said, you can take from the insurance companies that do well under the corridors, and you can take those who are not doing well, and you can shift money back and forth. And then if there's not enough to make up the deficit, because we're probably going to get some bad underwriting with these new people, then the federal government will make up the difference. And Rubio gets a bill through that says the Congress is not approving this money. So in 2014, do you know how much the insurance companies got that they were supposed to get under the deal they made to pass Obamacare? These subsidies they were supposed to get, they were paid 12 cents on the dollar because the federal money wasn't available. Now we have an underwriting problem. Isn't that a surprise? We offer a lot of coverage to sicker people who have not had coverage. They come piling in. The underwriting numbers are horrific. In my home state of Tennessee, they got 12 cents on their losses in 2014. They got a 60% premium approval for this year, and that doesn't catch them up for the losses they've had so far in the exchange. They're going to need to have 3 years of 60% increases to get back to breaking even. So this is not a solution. The insurance companies are fleeing it, right? The hospital companies, what's happening here? Well, there are more people covered. That's a wonderful thing. Except what happens, they used to come in and be covered for the things they wanted to be covered for. They had a modest deductible. Now they come in, they have these 10 essential services, and the family deductible is $12,000. So people that thought they had insurance don't have so much insurance anymore. If you're making $75,000 a year, and you've got to pay the first $12,000, you don't really have insurance. So some of the better run hospital systems, some of those that are in a position in the market to charge the higher prices, they're going to do just fine. There are a lot of those around the country, for-profit or not-for-profit, that are doing just fine because they can charge premium prices. They can make up for this. But half the hospitals in the country can't, and half those beds are unneeded. If you look at putting people in the appropriate place for what they need, when they need it, at the right cost, half the hospital beds would be empty. And everybody talks so glowingly, 16% in friction cost. All of that 16% is somebody's revenue. That's somebody's income. So who in this big deal of cutting the $3 trillion down to $2 trillion, who stood up and say, take a piece of that out of us? No, take it out of somebody else. Well, there's no somebody else for it to come out of. And the only solution for this is to turn things on their head and get the consumers empowered, informed, and charged so that they can begin to tell the healthcare system what they want and need with a collective voice that's loud enough to be heard. Right now, $500 million a year is being spent in Washington on lobbyists to keep things like they are. The existing players do not want this system to change. It's working beautifully. It's creating $3 trillion of revenue for players at all sorts of levels. And all of these attempts to say, well, we're going to break it down, we're going to make it more efficient, we're going to do whatever. When 16 or 20% is friction cost, and when you go back to the Beth McGlynn studies of a decade ago, I was on the board at Rand Health and Rand, which says that half the health care in America is inappropriate. It's not following any guidelines or principles. It's stuff that the evidence does not support doing, or there are things that the evidence says should be done, they're not being done because nobody pays for them. So we're not just trying to all of a sudden automate and come with all of this great technology to just make this system run a little faster and a little more efficiently. We've got to break down the whole system and reorganize how it works. And until you break away the funding from how it's organized, you're never going to be able to do that. Because all these startups companies, and I fund a bunch of them, and we do all these neat creative things that nibble around the edges of empowering consumers or making this mobile or telemedicine here or acute care hospital at home here. We have a company that now in agreement with the Marshfield Clinic is taking people in the emergency room who qualify for inpatient admission, and they're going home in many cases. Why is that? Because Marshfield Clinic has the health plan, the doctors, and the hospital. There's no reason for them at any level to put these people in the hospital if they can go home. And so let's say you've got a medical condition, you're recovering from a surgical condition, orthopedic surgery, you're going to have a day or two of acute care in the hospital. And so here's your choice. You can go into the hospital for that acute care. You can be in a room that's unfamiliar to you. It's going to be dark at night. You're going to be medicated. If you're older, you're going to fall and break your hip on the way to the bathroom, which is going to start the downfall of your health. If you all notice where the health starts dropping off for old folks, it's when they fell. And did the bone break and that made them fall, or did they fall and break the bone? Nobody knows. But it doesn't happen at home near as much as it happens in hospitals. And not many people get MRSA at home. The other thing that we've done as a hospital industry is wonderful. Do you know what we've done with medication errors through barcoding and the bans and the double checking and the timeouts and all the things we've done? Do you know the marvelous accomplishment of the hospital industry on medication administration? We're down to only a 10% error rate. Only 10% of the medications given in the hospital are given not according to the prescription. The wrong amount, the wrong dose to the wrong person at the wrong time. 10% error in the hospital. So if I'm a person who's come in, I've had hip surgery, and they say, we can send you home safely. We're going to send a therapist to your home. We're going to leave a nurse there for 24 hours. The doctor will come and see you there. You're not going to fall on the way to the bathroom. You're not going to get MRSA. You're not going to get crappy food. You're not going to sleep in a crappy bed with things banging up and down the corridor. And it's about the third the cost. Where would you rather go? Well, most patients would say, I'd probably rather do this at home. But the system doesn't really want you to do that. The system today doesn't want you to do that. What the system incents is to get people in at some point. So the primary care guys out there, they're like the guys at the mattress places that spin the signs on the side of the road. That's primary care. Get them into the system. Get them into the system. Then once we get them in, we've got the specialists, we've got the subspecialists, we can send them for diagnostics, we can send them to the hospital, we can do procedures on them, we can send them to step downs and subacutes and all these things, and eventually give them home health and spend all this money. And somewhere along the way, you could have told somebody who has lower back pain that if you had evidence and information that said, perhaps if you lost 45 pounds, exercised a little bit, didn't get your fingers yellow eating Cheetos watching Judge Judy and the Barca Lounger, get up and move around a little, okay, and lose the weight, maybe you won't have to have that orthopedic surgery you thought you were going to have. And what if the system could reward you for that? Could actually say, we will pay you not to have an unnecessary surgical procedure if you choose a less expensive, more conservative way to deal with your problem. Not that we're going to eliminate orthopedic surgery, but right now all the incentive is to cut on them, and to cut on them as many of them as we can. Let's take the poor patient who's coming up outside the hospital emergency room. So this patient is approaching the hospital emergency room. He's obviously in bad shape, and so some guy comes along with a gun or a knife and cuts the guy and takes all his money. What do they do to that guy if they can catch him? Put him in prison. What if the guy makes it inside the hospital and gets diagnosed and treated in a way and gets a surgical procedure he didn't need? Well, we pay the doctor $40,000 and say we saved a life. And in some cases we did. But in far too many cases we didn't. The emergency room is not where we should be giving primary care. Let's get primary care back out to the people. So with all this enthusiasm about change, the entire system is set up to make it not happen. The silos are existing to keep themselves in existence. There's an interoperability effort in Nashville now to say, let's at least make all these IT things and machines and clinical things in the hospital communicate with each other, because you get a nifty new app. Well, that doesn't work with Epic or Cerner or this or that, or who's going to write the interface. So we design the systems so that the information can't be aggregated together. I'm looking forward to today when it's not the health system that has the portal or the insurance company that has the portal, but the individual has the portal that says, here I am, here are my needs, here's a way I'm represented, here's a voice that can speak for me collectively with some breadth and strength to overcome all of these obstacles to people willingly giving up $1.5 trillion of income. They're not going to give it up willingly. And they can talk to you all they want to talk to you about how much they want to innovate and take cost out of the system, but talk to any company represented in this room or any place else who's trying to take their revenue down. Do you know anybody who's trying to get rid of that $300 billion? Anybody know of any of those? And what happens when we now consumerize all these things? Here's an interesting phenomenon that also occurs. So everybody's got insurance from their employer now. They got a little aches and pains, and they got the kids, so they got the Minute Clinic, right? They rush into the Minute Clinic. That has not replaced the primary care physician. That's just put an additional cost into the system. I'm willing to pay it out of my pocket because it's 40 or 50 bucks, and I don't have to wait a week or two to get it done when it's too late to go to the doctor anyway. So I'm willing to pay that cost, but it's not changing how healthcare is delivered. None of these things are linked together. And that's why I love the technology notion. How do we link them together? But it's going to be how do we link them together to benefit the individuals, not to benefit the organizations. And how do we save the hospital companies, the insurance companies, and the drug companies? How do we save the people as taxpayers and as employees who are now spending, what's the number now? $18,000 the average employer spends on health care for the employee. What if we could gamify health? There's a timer here somewhere, and I'm sure it's about to go off. If we could gamify healthcare a little bit, and I've got a friend in the gaming business who gets people to come into casinos and put $35 billion a year into machines that they have enough fun operating. They know they're going to lose money. They don't have it to waste, but they come in and spend, and he makes $100 million a year on the cash flow from that business. I'm trying to get him encouraged to come into healthcare. Help us teach people that the reverse is true. You don't have to play to win the jackpot. You won the jackpot. If you're a family of 5 and there's $10,000 health care spending per head in the country, right? So if you're a family of 5, the jackpot is the $50,000 you already have. That's yours at the beginning of the year. And what if we had information in front of you, people available to you, coaches who can help you, physician-led teams who can help you, advise you on how to use the healthcare system intelligently and give you bonus points if you do the right thing. We don't make you do anything. You can do it all just like you do it now. But if we could show you that if you avoid this unnecessary surgery and get a better outcome, ka-ching, you save some of those dollars. So at the end of the year, go buy a color TV with the money you didn't spend on an unnecessary surgery. I think I can sell that to people. You think you can sell that to people? A surgical procedure you don't need, which is going to put you in great pain and maybe cost you your life, versus you got your back pain fixed because you took some personal accountability, right? And you got to spend the money you didn't spend on health care on something else. They don't have any choice now. The money that's spent on health care, we spend on their behalf. And then we, the system, tell them we know what's best. Well, we don't. They know what's best. And until we empower them and find ways to get groups of people, and there are a lot of efforts in this room and others to try to do that, to get this to the individual so they can become part of the decision making. The other thing that has to happen, and this affects all those three, education, incarceration, and medication. The only way we're going to get any societal change or any behavioral change that we can measure on a gauge is not individual at a time. It can only be done in community. And if you look at organizations that work, they're built around community. Are any of you familiar with MediShare, the insurance company that's built around community? learn something about it, because you pay bills for other people, they pay bills for you. You don't have to pay bills for things you don't think should be done. It's all voluntary. Your money's banked into your account. If it doesn't get spent, you get it back. And they provide health insurance for 200,000 people for half what their cost would be in the commercial market, with better results, happier people. So you now get a note that says, Joe Jones paid for that MRI that you have to have. You don't use your bank account to pay for your expense. You use it to pay for somebody else's expense. And if you have a medical expense, somebody else pays for yours. And you get the note with a little prayer card. Now, you can build this around Christian, Jewish, Muslim, agnostic. You know, we can have an agnostic affinity group. It just needs to be a group of people who will surround themselves with others of like mind, act collectively in ways that are intelligent, and they can change the system. It's never going to be changed from within. It's not going to be changed with policy. I sat on the RAND board for years and beat my head against the wall on policy. Can't be changed that way. The stakes are just too high for those who are vested. And the only way to get it is into the hands of the people. We can do that with technology. Technology will speed that. So if you take all the friction and waste, and I'm invested in a little company that's involved in blockchain in healthcare, which is an interesting little space, because most of that 16% friction cost really doesn't need to exist at all. There doesn't need to be most of what's in between. Accounts receivable, accounts payable, supply chain management, all the people in healthcare that work in these functional areas around getting the bill out and collecting money and getting the supplies in and paying the supplier, right? And the activities associated with those things and getting the clinical information collected. What if everybody were required? If you're a provider to anybody in my system, you have to give us information that we can drop through their portal into their personal health record. It's not yours. We're not going to be your patient unless you give us this information. So now what if we had this information? Locally, we're organized into groups that can act, and we can speak with power. And then we can, with power, turn the system upside down. So I'm out of healthcare as a provider. I'm here as a revolutionary, a flamethrower, a crazy old guy who's gone off the ranch. But I think there's real hope that we're getting close to the point. I tried to do it inside the system for 20 years, 50 years. 25 years ago, I had 1 million people, full risk in Southern California. I had IPAs and hospitals. We were a closed system. We and the doctors owned the system 50-50. We had transfer payments. Whatever we made or lost, we shared with the doctors. We did it for less money, better outcome, better patient satisfaction. But then all of a sudden it comes along and we can't be at risk with doctors financially. I can't make it level so that neither of us cares where the patient is. If I'm taking the risk with the doctors, I don't want them in the hospital if they don't want to be there. If the physician is at risk, they don't want them in their office. If they're a specialist, if they could be taking their chronic care to a primary care provider and treating it in other ways. Everybody's got incentive to do the right thing for the patient at less cost with better outcome. But that doesn't last very long because he gets thrown over by PPO. Now everybody wants free choice. Cost is not a big issue, so HMOs kind of went away. But we were being very successful with that model 25 years ago. Here's the last thing I'll give you and I'll leave you with. I owned and operated a hospital up in Worcester, Mass. Great place. Love the state of Massachusetts. I like New Hampshire even better. I went up there when I worked for HCA and built a hospital, and when I rode in it said, live free or die, I said, I don't think these are these Eastern liberals I've been hearing about up here in New Hampshire. I think these will be our kind of folks. And they actually understood Tennessee up there, so we did very well in New Hampshire. But down in Massachusetts, not so good, because we had the St. Vincent's Hospital out in Worcester. We had the Fallon Medical Group, the Fallon Health Plan, which got put in place because Blue Cross 40 years ago wouldn't put an HMO product in the market. The Fallon Clinic went and said, let's put a model in for an HMO type model. Blue Cross said, no, do it yourself. So they built the Fallon Health Plan, and for years it was the most successful one in the country. They had 99% renewal rates, great customer experience, good cost control, et cetera, et cetera. So I'm up here running this hospital in Worcester, St. Vincent's. We built a new 350-bed facility that's hospital, clinics, doctors, integrated financially in a legal way so that everybody had stake in the whole game. and things are going well. But now we have an effort in Massachusetts to control costs. So it very frustrates me when I sit up here and I look at UMass a few blocks down the road. I've got a newer building, better doctors, better clinical outcome, better patient experience, better HCAP scores, measures any way you want to measure us. We outperform them, and Blue Cross paid them 40% more than they paid me because they were UMass. And guess what? If they could get this Worcester guy to go all the way into a Partners hospital, they pay him 100% more than they pay me. 100% more for the same thing I can do in a beautiful, modern, well-equipped hospital, top quality physicians, right here in your hometown. But if you'll go down and get in a Partners hospital, we'll pay twice as much for the same thing. Now the state's worried about cost control. Guess what they want to do? I had the most profitable hospital in the state, the lowest cost, the lowest rates, the highest profit margin, and they were trying to figure out how they could keep us from making so much money. So what we need to do is we need to take everybody in the system and reduce what we pay them by 3 or 5%. So let's reduce Partners and UMass and St. Vincent's all 3 or 5%, and this is how we get our arms around cost. Why don't you get your arms around cost about taking people you're paying 200% for and leave them in the place they live where physicians and facilities can take care of them, and do that for half the cost? That's how to get cost under control. But I'm telling you, the legal, the political establishment, because the liberal politics, the Harvard, the Partners, the cabal up there, that's going to be like it's going to be forever. And God bless you if you want to go up there and be a provider of high quality, low cost care that people really like, because the system will just crush you to death. Very encouraging. So I just got the hell out of the hospital business. I'm through with it. I do this wonderful work. I can't get rewarded for it. So now I'm on the other side. I'm a flamethrower. I hope a lot of you in here are flamethrowers. We don't need to be tinkering around the edges. We don't need to find a way to automate an unnecessary process. I found in trying to make hospitals run more efficiently, the worst thing that could happen to me is to have a department that performed better than any other hospital in the system. They had the highest performance metrics in some area than any hospital in my system, but they were doing a completely unnecessary task. It's really hard to root out economic efficiency with unnecessary things. Really hard. If you're doing it well and better than the other folks and you meet up on the bars, that's good, even though the whole underpinning of what you're doing may be completely unnecessary. We've got to change all the processes of care until we get into how care is delivered from top to bottom and put people in control, get the politics out, get the finances separated from how the systems are organized. We're not going to get there, but I'm working my fanny off, and I have a lot of like-minded people around the country and around the world who think there's something here to this empowerment of the people, and a lot of you are involved in that. I welcome you to that journey, and I hope I don't get killed on the way home. Thank you.